President of the Metastatic Breast Cancer Network. Before our presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, metastatic breast, ovarian, and uterine cancers for the last 45 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, please visit SHARE's website at sharecancersupport.org. Today, all participants in this webinar will be muted during the presentation. When Dr. D'Abrio finishes presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. When asking questions, remember that Dr. D'Abrio is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. We also would like to thank Puma for their sponsorship of this webinar. Now, I'd like to introduce our speaker, Dr. Nina D'Abrio. She is a medical oncologist and the medical director of the NYU Long Island Breast Cancer Program, which is part of NYU Langone's Perlmutter Cancer Center. She is also an assistant professor, NYU Long Island School of Medicine, and is actively involved in teaching fellows, residents, and medical students. Her clinical expertise is in the management of all stages of breast cancer, as well as benign high-risk disease. Dr. D'Abrio is the local principal investigator for breast cancer therapeutic clinical trials at NYU Langone and is also participating in a registry trial in early stage breast cancer with investigator-initiated sub-studies that integrate biological and molecular studies with patient survival and outcomes. Welcome, Dr. D'Abrio.
Well, thank you. Thank you very much for that introduction, and thank you to SHARE for giving me the opportunity. I will start sharing my slides so that we can get started. Please let me know if there's any technical issues, but without further ado, I think the landscape for HER2 new breast cancer has dramatically changed over the last few years, and I'm happy to present some of the updates where we are currently at the end of 2021 and where we're going in 2022. So I have no disclosures. So the HER2 new or ERBB2 protein, as we know it, is a protein that's on the surface of cells. As you can see, both normal breast cancer cells as well as, I shouldn't say normal breast cancer cells, normal cells, as well as the HER2 positive breast cancer cells have an expression of this protein. But when the protein is overexpressed, that's what we define as HER2, when there are too many of these receptors on the surface. So the HER2 protein or receptor is actually encoded by the ERBB2 gene. This gene is located on the long arm of chromosome 17, and overexpression of that protein occurs either because there's an amplification of the gene or some other type of mutation, and that is found in approximately 20 to 25% of women with breast cancer. And I want to point out that every cell has HER2, but overexpression is defined really by the way we stain or the way we test for HER2, and that's what we call amplification. So the ERB family or the HER2 protein is actually part of a family of receptors. These are what we call transmembrane receptors. They straddle the cell. So there's a part that's outside the cell and there's a part that's inside the cell. This is bound to the cell membrane, and it's what we call a tyrosine kinase. It's activated by binding of phosphorylation, and it's involved normally in pathways that lead to cell growth and differentiation. So HER2 on its own has a role in normal cell growth. The way the protein is activated is important because that drives some of the technologies we use to develop therapeutics for this disease. When two members of the HER2 class, the two HER2 proteins join together, it's what we call a homodimer. And then if it binds with members of its class, that's a HER1 or a HER3, it's what we call a heterodimer. So HER2 is activated either by binding to another member, another HER2, or to other members of its class. And that actually is important to understand when we're developing drugs for this disease. So as I said earlier, what we define as HER2 positive clinically is really based on testing for the receptor, which was a huge advance in both the treatment of breast cancer as well as in prognosis. So testing for HER2 involves two mechanisms. One is what we call immunohistochemistry, or IHC. And what you can see here is IHC is using an antibody that tags this receptor. And you can see that stain on a cell. A pathologist can estimate the amount of stain. What you can see here is the interpretation when there's no stain, it's essentially zero, a faint, a very minor stain, 2+, and then 3+, which is a strongly positive HER2. So as you can see, there's a lot of, these technologies are fraught with a lot of issues sometimes. You have to make sure the stain is correct. Sometimes you have to make sure the person reading is correct. So there's a lot of quality control that goes into identifying HER2. Typically, the cells that are 1+ or 2+, or the cancers that are 1+ or 2+ are defined as HER2 low, which is not to say that the ones that are completely zero may not have HER2. It's just that they're not really detected, or they are not as evident on staining. The ones that are 3+ are defined as the strongly positive or the clear HER2 positive. We all know that just IHC staining is not enough. Sometimes there are some cells where the staining may be fraught with issues. We need to confirm that. So another way to confirm is what we call FISH testing, or fluorescent in situ hybridization. So unlike the IHC, which looks at the receptor on the surface of the cell, the FISH testing actually looks at the gene inside the cell. It looks at the amplification of the gene on that chromosome 17. So these green signals here are actually the chromosome, or what we call the centromere of the chromosome that is stained, and the red signals are the HER2. And if we find that there is a lot of red compared to the green, then we know that that gene is amplified, and ergo that could lead to amplification of the protein or the receptor. So in cases that are unclear, where they are 2+, we generally would reflex to doing a FISH test to confirm whether this is truly amplified. While the definition of HER2 has undergone, or HER2 positive has undergone, many evolutionary changes over the course of the last few years, we know that IHC 3+ is clearly positive. We know that IHC 2+ needs confirmation. And it's not just the ratio of the red to green, but it's also the number of copies of the gene that matter. So there are many definitions now of what is HER2 positive, both based on the IHC and the FISH. But in general, if the ratio is greater than 2.2, or the copy number is greater than 6, those patients will still be considered to be HER2 positive. So why do we need to know this? That's because as you well know, the receptor status is not just prognostic. It not just tells us how cancers behave, but it's also predictive. It tells us what kind of treatment to use. And I have this slide here to just show you what we define as better versus worse prognosis. And really, treatment has changed this algorithm substantially. But we know that traditionally, cancers that are estrogen positive and HER2 negative happen to be more indolent or less aggressive. Apologize. But as we go down the spectrum here, there are some HER2 positive cancers that are what we call triple positive, which are positive for the estrogen and progesterone receptors. So if all three are positive, they are what we would define as a luminal HER2. And then we get to the ER negative HER2 positives. So as we go down the spectrum, the behavior, the biologic behavior gets more aggressive. and so do the treatments. They get more aggressive. So how do we target this HER2 receptor? Very quickly, and I know that there's been so much research and buzz about these drugs. There are three main classes, and they're all based on knowing the biology of the receptor. The first are the HER2 antibodies. We're hearing a lot about antibodies today in the setting of the pandemic, and the antibodies do exactly what they promise. They target the receptor. They target one certain area on the surface of the cancer cell. In the case of HER2, probably the granddaddy of all antibodies here is the trastuzumab, or what we know now as Herceptin, or call Herceptin. The three antibodies that are that act on the outside, on the part of the receptor that's outside the cell, are trastuzumab, pertuzumab, and then the newest kid on the block is a drug called margetuximab, or Margena, which has just been approved by the FDA. Apart from the HER2 antibodies that are straight up proteins that target the receptor, the newest breed of drugs we're now seeing is a combination of antibody and drug, or antibody and chemotherapy. The promise of these drugs is that they also not only target the receptor, but they can also deliver small doses of chemotherapy directly to targeted cells, and thereby minimize the sort of toxicity that we've seen with traditional chemotherapy. Familiar to us are trastuzumab emtansine, or TDM1, also known as Kadcyla, trastuzumab deruxtecan, or TDXD, which you may know as Enhertu, and then another drug that's in studies right now is trastuzumab duocarmazine. This is just the very tip of the iceberg. There are many, many other of these ADCs, or antibody-drug conjugates, that are being studied. The last class of drugs is the anti-HER2 small molecule tyrosine kinase inhibitors. I told you that the receptor has what we call tyrosine kinase activity under the surface of the cell, or intracellularly. This is because once the two receptors bind to each other, they activate this tyrosine kinase pathway. And that leads to what we call downstream signaling, which ultimately leads to growth of cells. So another way of targeting these receptors is hitting them from below. So instead of just binding from the surface of the cell, maybe we can just block how they get activated once the receptors have bound to each other. The advantage here is that these medications are generally small molecules. They penetrate very well. They also happen to be pills for the most part. So they're oral compared to some of the other drugs, which are either intravenous or subcutaneous drugs. And some of these are familiar to you again: lapatinib, neratinib. Our new one to the arsenal is tucatinib, or Tukisa, and a drug that was just presented at San Antonio, the San Antonio Breast Conference a few days ago, pyrotinib. So let's talk a little bit about where we are today. As you can see, the HER2 timeline has accelerated over the years. You can see the timeline from when the HER2 gene was first identified to the discovery of or the approval of trastuzumab took a fairly long time. But since then, from 2010 onwards, we've been seeing rapid approvals and rapid development to where we are now. I haven't included 2021, but the last two approvals we have are for Tukisa, tucatinib, and then we have on HER2 that was just approved. We also have Margena, or margetuximab, that was also approved, which is the one that didn't make it to my slide. What I also want to point out for those of you interested is that it's not just breast cancer that's seen this upswing. We know that the HER2 protein is expressed, and there are other cancers that may also be driven by the HER2 receptor. And that's why these drugs are also being studied in other tumors, such as gastric cancer, bladder cancer, biliary cancer. So there's a whole new world of therapies available, not just for breast cancer, but also for other types of cancers. So let's talk a little bit about the individual classes. The HER2 blocking antibodies, as we talked about with the earlier slides, trastuzumab, and I will put up there the biosimilar drug, Kanjinti. I'm not going to go into the patent laws and why these things happen, but we do know that the biosimilars have similar clinical activity to Herceptin because they have been tested in the same. So it's essentially the same drug or the same active antibody. The same drugs are available as in different formulation. Another huge advance for our patients. Instead of IV, we can now use these drugs in a subcutaneous format. And thanks to technology, we can now shorten times that patients have to be in the infusion center. These drugs also have been proven to be just as effective as the parent IV drug. So though I listed them separately, they're essentially the same drug. So subcutaneous trastuzumab in combination with hyaluronidase that allows it to penetrate. Pertuzumab, which is the other companion drug of trastuzumab, and the subcutaneous formulation of the two together. And lastly, the margetuximab. So trastuzumab, again, as I like to call it, it is definitely one of the first well-known antibodies. It almost didn't get approved. It was a drug that was overlooked for a long time until one of the legends in oncology, Dr. Dennis Slayman, went back to the drug and recognized its activity. This drug binds to the HER2 receptor. And as I told you in the very beginning, there are many mechanisms of activity, but what it does is it blocks the binding of HER2 to another HER2 antibody and prevents the homodimerization. By doing that, it also downregulates the HER2 receptor. So that in itself is the main mechanism of action, but there is studies that show that it's not just blocking the antibody or the receptor that matters, blocking the receptor with the antibody. Once the receptor is blocked, there's also something that happens downstream or beyond just the blocking of the receptor, where there is modulation of pathways below that receptor. And there's something that we call antibody-dependent cell-mediated toxicity, which is when the antibodies are blocked, they do in some way cause cytokines to be released, and they activate immune cells that can then destroy cancer cells. So it's not just the mere binding and blocking of the antibody. There's also an immune activation phenomenon that may actually explain some of the effects of these antibodies. We do know that some of the side effects of these drugs are pertinent to where we find HER2 receptors normally. We find HER2 receptors on the heart muscle and in the lungs, in the bronchioles. And the two most common, the most common side effect is reversible heart failure. What happens is that because it binds to the receptor on the heart muscle, it can reduce the pumping activity of the heart. A lot of times this isn't evident to patients. It's not evident in the clinic. You're not symptomatic, but this is why we check the heart function with an echo when patients are on Herceptin. It is reversible because as soon as the drug is taken off, the binding activity reverses and the function of the heart can recover. A much rarer side effect is pneumonitis or inflammation of the lung. It's very uncommon, but it's something that we are aware of and watch for in patients on any antibodies. The other drug that is a companion drug is pertuzumab, and pertuzumab is actually complementary to Herceptin. This is the receptor, and we just discussed how trastuzumab binds to a different part of the receptor and prevents binding. The pertuzumab, on the other hand, it also binds to the receptor and prevents this dimerization or binding of two receptors, not just HER2 to HER2, but also HER2 to HER3, but it binds at a different site. And by binding at a different domain, as we call it, it has a complementary activity in binding the receptor. It can also induce ADCC, but it really works as a complement to the Herceptin, which works slightly lower down at a different domain. It can have the same side effects as the Herceptin. We do see the reversible heart failure. And in addition, some of you may be familiar, there are some GI, gastrointestinal side effects, in particular diarrhea and bloating that can happen with this drug. The last drug that I'll talk about today is Margenza or margetuximab. This is a unique antibody which binds to certain parts of the HER2 receptor. What we found is that it binds much more tightly to something called the Fc receptor, and it actually has enhanced ADCC or immune activity compared to the trastuzumab and the pertuzumab. So this drug has an increased affinity for a certain type of receptor, a certain type of genotype of this receptor called the CD16A. And while the studies that were done show benefit across the board, we may actually see the most benefit in certain patients who are carriers of the CD16A or whose HER2 receptors are of a certain genotype called the CD16A. At present, we are not testing yet for this receptor, but it's certainly the focus of interest for research interest to figure out who are those patients who benefit most from this drug and how do we test for the CD16A158 receptor type. In addition to the heart failure, which is a common class effect, this drug does cause some blood reactions, infusion reactions, and in some cases, it can also drop blood counts. Again, very reversible, but and unlike traditional chemotherapy, the blood count drop is not a dramatic drop, but it has a slightly different profile. The second class of drugs are the antibody-drug conjugates. These are fascinating drugs and a marvel of engineering. They have three components. There is the antibody, and I'll start at the bottom here, the antibody, which we just talked about. There's a linker that links this antibody to something called a payload, or this payload is the actual chemotherapy or the cytotoxic agent that kills target cells. So in addition to just using the antibody, we're now able to attach a chemo drug which can only target cancer cells. And that is the sort of an advance in just using traditional chemotherapy. We know that antibodies on their own work well, but they usually work well when combined with chemotherapy. This mechanism or this technology allows us to combine them together and still deliver the chemo just to the cancer cells. There are three that are probably familiar to you, or two rather, the TDM1, Kadcyla, the HER2 or TDXD, and then the newest kid on the block, as I said earlier, which is being studied, which does not have a name yet, trastuzumab duocarmazine. This is the third drug that is currently in trials. So how do these work? As we discussed, you have the antibody-drug conjugate. You need a receptor for it to bind to, and therein lies the importance of knowing the HER2 status. Once you have a receptor, the antibody-drug conjugate is internalized. The linker releases the drug while it's in the cell, not when it's outside, and then it releases the chemotherapy, which then causes cell death. So on the surface, this seems to be a very simplistic mechanism. Yes, the drug needs a receptor to bind to. If it doesn't have a receptor, maybe it's not going to bind. The question is, how much of that receptor does it need? Do you need to have multiple HER2 receptors, or can you be HER2 low and still have the drug work? So what we know now is that these ADCs not just kill the HER2 cells, but they also have a bystander effect on surrounding cells. So this bystander effect, if I may draw your attention to B, where once the drug is internalized, you release these molecules of the drug, but these drugs can also diffuse back out of the cell and kill cells that are around it that may or may not have HER2. So it can kill the cancer cells all around. And the extent of that bystander effect really depends on the drug to antibody ratio. There are some drugs that some of the conjugates that have a lot of the chemo molecules attached to it. The higher the number of chemo molecules, or what we call payload, the greater the potency or the greater the bystander effect. As you can imagine, if you have a very few HER2 receptors, but if you have a larger amount of chemotherapy, all you need is a few receptors, which is one of the reasons why some of these drugs not only work for strongly HER2 3+ positive cells, but we're also seeing activity in the so-called HER2 low, and in some cases, even the HER2 negative cells, because as we defined earlier, the definition is really based on what we're doing in the lab, on the way we're testing the HER2, but the receptor exists on all cells. So just to draw home that point, or to bring home that point, these are two different antibody-drug conjugates, TDM1, and the other one is HER2 or TDXD. The payload or the chemo part is different. In the case of TDM1, it's emtansine, which is a drug which is similar to a Taxol in the sense that it's what we call a microtubule agent. And in the case of HER2, it's a drug called deruxtecan, which is slightly different. If some of you may be familiar with topoisomerase inhibitors, drugs like irinotecan that we use in colon cancer, this drug is similar to that. So they have two different chemo drugs that are attached to that. The antibody-drug ratio for Kadcyla is 3.6, whereas the ratio for HER2 is almost 8, it's 7.9. So a lot more chemo attached to the drug. They both bind to HER2, but because of this very high payload and because of this high drug to antibody ratio, it's also effective in patients that HER2 rather can also bind to patients that are HER2 low, or tumors that are HER2 low, not necessarily just the HER2 3+. The side effects are also different. With TDM1, in general, we see higher liver function tests. Sometimes we can see neuropathy, which is tingling and numbness in the fingers, low platelets. But T-DXd has a slightly unusual and different side effect. It is similar to what we see with pneumonitis, but with HER2, but it's much more common with these drugs. There's something called interstitial lung disease, which is definitely a reason that I know these drugs have been studied extensively, because while they're very effective, we know that side effect management is a big part of treating patients in the real world. And so the interstitial lung disease is something that we're very, very aware of. As I'd shown you in the earlier slide, the bystander killing effect of the T-DXd is much higher, and that's because it has a much higher payload, a much higher drug to antibody ratio, and so it can also kill the HER2 low cells. Coming to the oral tyrosine kinase inhibitors, the ones that are familiar to you again are lapatinib, Nerlynx, neratinib, and Tukisa or tucatinib, and most recently pyrotinib. The beauty of these drugs is that they're oral. Also, because they're very small molecules, we know that some of them can cross the blood-brain barrier. In fact, all of them do to different degrees. It used to be thought that most other drugs didn't cross the blood-brain barrier. That may change with some of the antibody-drug conjugates. We are starting to see some activity of even the antibody-drug conjugates in the brain. But as of now, as of 2021, we know that one of the advantages of using these oral tyrosine kinase inhibitors is that they can cross the blood-brain barrier, and they can attack HER2 positive cancer cells in the brain, which heretofore has really been the holy grail of treating HER2 cancers. They have a slightly different profile, and that's really based, or the side effect profile is based on how selective they are for either the HER2 or the other members of the class, the HER1 or the HER3. So as you can see, the lapatinib, the Tykerb, and the neratinib are non-selective, and so is the pyrotinib, which means that they target not just the HER2, they can also work on the other receptors. And by doing that, they can cause diarrhea, they can cause rash, and then the reversible heart failure, which is much less common than the antibodies, but it's definitely a class effect of the HER2. On the other hand, tucatinib is much more selective for the HER2 receptor. And by as such, the side effects are a little lower. They're much more specific to HER2 rather than HER1, which is what causes the diarrhea with the other drugs. These drugs work downstream, as I had mentioned. We also know that on their own, they're not always completely effective, and they're usually used in combination with other drugs in order to make them more effective. And that really drives home the point that even though we show you we all know there's a cartoon that shows you a receptor with one pathway, we know that cancer cells do get smart and they develop resistance because they know ways or find ways to bypass some of these simple pathways. So we're constantly searching for ways to block pathways, not just in one way, but in multiple ways. Let's switch gears a little bit to talking about how to put all these drugs together. So in our toolkit, we have 3 different classes of drugs. How do we put them together? Well, it starts by knowing that breast cancer is not one disease. We know that there are several stages of breast cancer. And in general, the way we treat early stage breast cancer is a little different from the way we treat metastatic cancer, because early stage breast cancers behave differently. By early stage, I mean cancers that are stage 1 to 3, where surgical removal is still possible. For metastatic cancers, it does, as you well aware, this group, I'm sure certainly needs no introduction to this concept, where the cancers have traveled outside the breast and the lymph nodes, and where we are trying to control the spread and trying to minimize spread to other areas and to reduce resistance. We also know that just knowing the HER2 receptor is not enough. I showed you a slide earlier explaining to you how the prognosis changes along with the expression of other receptors. And the 3 receptors that matter most are the estrogen, progesterone, and the HER2, but again, combinations matter. So cancers that are triple positive may have a different prognosis than cancers that are hormone negative and HER2 positive. So this particular middle bucket is really what we're going to focus on, the triple positive cancers that are positive for the estrogen and the HER2 receptors, and the ones that are hormone negative and HER2 positive. And more, we're coming to realize that we can't lump all these cancers in one bucket. We may need separate trials for a triple positive HER2 cancer versus a ER negative or a hormone negative HER2 cancer. So where do we stand at the end of 2021? And I've tried to divide this into two categories. One is the early stage and one is the so-called metastatic or recurrent stage. There are certain buzzwords or themes that you will keep hearing at several conferences or talks. And one is for small cancers, we want to try to de-escalate or reduce the amount of chemotherapy. And then we also want to optimize, or we want to tailor treatment based on what we see when we treat these small cancers with chemotherapy. One of the buzzwords or one of the things we've learned about breast cancer is that the response to treatment, or what we call the pathologic response, matters. Cancers that can respond well to treatment and achieve what we call a complete response tend to have a better outcome. And so a lot of our therapies, especially for more aggressive cancers, are geared towards treating cancer while it's still in the body, or what we call neoadjuvant therapy. And certainly for larger cancers, our goals are always to try to achieve the PCR, which has been shown in multiple trials to be a good surrogate for outcomes, for survival outcomes. In the case of metastatic cancers, our goals are really to improve therapy, to improve resistance, or to overcome resistance, because we know we're in for the long haul with patients. We know we have wonderful success stories, patients going many years, and not all cancers respond the same. So we really want to find those patients where the cancers get resistant early. We want to give them treatments that can give them a long time before moving to the next treatment. Brain metastases do remain an area of concern with HER2 cancers in particular, and our constant search for drugs that can not only show that they can prevent or reduce breast cancers at the early stage, and we're not quite there yet, but also treat breast cancer metastases without the toxicities of radiation. And then the last area that you're hearing about, we're hearing about more, is the HER2 heterogeneity, low HER2 versus high HER2 cancers, or HER2 that's triple positive versus HER2 hormone negative cancers. So they're not one group. And as I said, we probably need trials that attack these drugs, attack these groups of cancer cells differently. So Herceptin, again, this is old history, but we have wonderful studies from 2006, where Herceptin was approved. We found that it was best used in combination with chemotherapy. We had wonderful trials that were done, and kudos to the women who participated and men. There were about 13,000 patients in all, and all of this got us the approval for Herceptin back in 2006, with a 50% improvement in disease-free survival and a 30% improvement, 30% living longer. With the addition of Herceptin to traditional chemotherapy. And in 2012, the addition of Perjeta or pertuzumab also improved upon that. So we know that these two drugs in combination with chemotherapy work very well. However, the chemotherapy that was used was pretty heavy duty, as some of you can attest to. It was usually multi-agent or multiple chemotherapy drugs. So the question really is, how do we treat nowadays in 2021? Well, first of all, for patients who have very large tumors, or tumors that are more than 2 centimeters, or lymph node positive patients, these are the cancers that are traditionally high risk, we still use the strategy of what we call neoadjuvant therapy. And the reason for that is because neoadjuvant therapies can assess tumor response. We can see what's happening to the tumor in real time. It allows tailoring of treatment after, based on whether or not there's a response. We treat micrometastatic disease early. We know that even though the seed is still in the breast, we know there could be tiny cells that could float around, and those are the ones that we're trying to kill. So the treatment early on, systemic treatment early on, really helps. It also may reduce the extent of surgery. If there's a large tumor and you want to shrink it down, and somebody who had many lymph nodes, if you can make them negative, it might reduce the amount of surgery and side effects from the surgery. The standard therapies we use, of course, I think, again, I won't go into many details, but it's usually a combination of 2 chemo or 3 chemo drugs, along with Herceptin and Perjeta. And if there was no cancer left behind at surgery, what we call a PCR, we would consider continuing Herceptin and Perjeta to complete out 1 year. And if there was no PCR, or if there was some residual disease, we've also gotten smarter at how to make the outcomes better. Now we would transition to TDM1 or consider a trial. For extremely high-risk tumors, in particular those that are triple positive, there's also studies looking at adding an oral drug for a year after completion of the Herceptin biologic therapy for 1 year. So we have improved outcomes incrementally in patients by not only optimizing treatment before, but also tailoring treatment at the back end. So the question really comes is, do all tumors need 2 or 3 chemo agents? Do we really need to do this for every single patient? What about the smaller cancers, the cancers that are under 2 centimeters or have negative lymph nodes? We know that stage for stage, HER2 cancers, even though they're small, are more aggressive than HER2 negative cancers, but they still have very good outcomes, as you can see here on this slide. They still have fairly good outcomes. So do we really need to use more chemotherapy in these very small cancers? So the answer is not necessarily. And the trials that showed us that patients who have very small cancers can do just as well with less chemotherapy. The first was the APT trial, where instead of 2 chemo drugs, we now use a single drug, Taxol, along with Herceptin for 1 year. And it showed that patients had a really, really good 7-year disease-free survival. As you can see, it was in the 90% plus range. Slightly lower for HER2 hormone negative patients, slightly higher for hormone positive, but all patients had an excellent disease-free survival beyond the 90% range. In fact, on these trials, we have just seen about 4 deaths overall in this entire cohort of patients, even at the 7-year point. So we know that smaller cancers can be treated with less chemo, or what we would call de-escalation. So less chemo, just as effective. So moving on to where the standard approach is now at the beginning of 2022, low risk cancers, we would use less chemo with trastuzumab. For intermediate or high risk cancers, we would use neoadjuvant multi-agent chemotherapy with trastuzumab and pertuzumab. And then depending on whether there was PCR or not, we would continue either the same treatment or we would transition to TDM1. What about the future? Where are we beyond this? Well, first for the small cancers, first of all, we know that we're still using chemo. So the first attempt we made, and no pun intended, the attempt trial looked at substituting the Taxol with Kadcyla. That was the only ADC we had a few years ago. And this trial was done really to see whether we could minimize side effects by substituting the chemo part with TDM1. Unfortunately, it did not quite meet its endpoint. There was actually no difference in the discontinuation rates. Patients still seemed to have side effects. So the drug was not approved in this situation for early stage small breast cancers. But we haven't given up yet. The researchers at Dana-Farber are planning attempt 2.0, which we will be opening up at NYU as well, where they're going to be using TDM1 followed by Herceptin. The thought was that the neuropathy and the low platelets and other side effects from TDM1 did not quite replace Taxol. So maybe instead of using a whole year, we could use 6 months of TDM1 and 6 months of Herceptin. And that concept is being studied in attempt 2.0 for small cancers. What about tumors that are slightly larger, node positive? Can we try to tailor therapy even further? Can we try to de-escalate even these slightly more aggressive cancers? This brings us to the COMPASS group of trials, the COMPASS HER2 trials, where we're trying to use less chemotherapy before surgery. This is a national trial. It's open throughout many centers in the United States, including at NYU, where patients with larger tumors, including node-positive cancers, are now randomized to getting less chemotherapy. And then based on whether or not there's a PCR, they are being randomized to either continuing the same treatment or there's an option to enroll in other studies. So it's currently open at multiple sites, and it's really exciting to see how we could use less chemo in some patients. How about just no chemotherapy? Can we just use biologics? As of now, our concern is that we don't have much data here, but there is some studies in older patients where we can just use, this study was done, is an Asian study where in older patients, we found that the lost survival from omitting chemo was less than 1 month at 3 years. For certain patients, we would still use Herceptin, but try to avoid the chemotherapy. Some of our German colleagues are looking at doing the same in patients with hormone negative cancer. Again, San Antonio had some data showing that in the chemo-free arm, some patients still had PCR, especially if they were HER2 3+. Not ready for prime time yet, but certainly more to come in 22. Same thing with the triple positive cancers. We're starting to see some data from our German colleagues where they're using just TDM1, and they are seeing some PCRs with non-chemotherapy regimens. Let me move on to metastatic cancer, so we have time for questions later. HER2 metastatic breast cancer has come a long way. We still see brain mets being a big area of concern. 30 to 50% patients still develop brain mets, and certainly an area of interest for all of us is identifying who these patients are when they have early stage cancer, rather than when they finally present with metastatic cancer. I will quickly summarize. Our frontline treatments are still a combination of chemo with trastuzumab, pertuzumab, which still gives us the best long-term survival in these patients, right up to 8 years. We are now adding TDM1 in the second line in 2021, though that was to change very quickly. We now have new drugs that are seen in this, as you can see, that are all here at the bottom. There are some drugs that are moving up in this arena. TDM1 in particular, just shown at San Antonio to have a dramatic improvement, 72% over TDM1, and that may soon be overtaking Kadcyla in the second line setting. The HER2 Climb data showed us that tucatinib, which is an oral drug that penetrates the blood-brain barrier, was also effective in patients who had brain mets that had not been treated with radiation. So for the first time, we have a drug that can penetrate the blood-brain barrier and have an impact there without toxicity. So ENHER2 has moved up, TDXD. There was a 72% reduction in progression in patients who had received prior therapy, including patients who had treated brain mets or had their prior brain metastases treated. The interstitial lung disease is an issue. However, we have gotten smarter since the phase 1 studies. We're recognizing and treating it better. And so we're able to reduce the risk of significant or severe interstitial lung disease. So a few pearls, we always rebiopsy when there's a metastatic site. We always retest for HER2 because you never know when a cancer may flip its nature, and patients may be eligible for these drugs, even if they were HER2 negative in the beginning. We still use chemotherapy in the front line, but ENHERTU is moving up if there are treated brain mets. In untreated brain mets, for now, we are using tucatinib, though there are ongoing trials looking at combinations of ENHERTU with some of the oral drugs, getting the best of both. But as always, it's always toxicity balanced with efficacy. We could have the best drugs in the world, but it's the patient that matters. It's the side effects to an individual patient that matters. So we always have to bear that in mind when we are, I shouldn't use the word playing with, or when we have these wonderful drugs, we get so enthusiastic about these drugs. So finally, I'm going to leave you with this slide. This is our current arsenal of clinical trials that we have ongoing. We have the COMPASS for the early stage breast cancers where we're using less chemo. We have the COMPASS residual disease, where if patients do not achieve a PCR, they are randomized to either getting Kadcyla or Kadcyla plus tucatinib. We have eMonarch-HER, which is using a drug called Verzenio or abemaciclib to patients with triple positive breast cancer and adding it after they finish their HER2-driven therapy. As we said, this is a special group of HER2 patients that are also estrogen positive, and we're trying to see whether we can minimize resistance. Attempt 2.0 will be opening, where instead of using Kadcyla for a whole year, we'll be using it for 6 months, followed by Herceptin for 6 months, versus chemotherapy and Herceptin for 1 year. In the metastatic side, we are looking at a trial that's currently open nationally. It's open at NYU using immunotherapy in combination with taxane and Herceptin and Perjeta to see if that improves outcomes in the front line, the first setting. The Destiny-07 is open, which is a combination of TDXD with a variety of different drugs, as I talked about, to try to get the best of both. And then finally, there's a new ADC that we have just opened at NYU. It's a different antibody-drug conjugate in patients who have progressed beyond ENHERTU, TDM1, and tucatinib. And that's it. A summary, it is more aggressive, even smaller cancers, but we've come a long, long way. We've de-escalated, we've optimized. We know that triple positive cancers may be treated differently from hormone negative cancers. Subcutaneous and biosimilars are just as effective. There are a lot of improvements in the outcomes of patients with brain metastases, and there's still more to come. Thank you.
Can I be heard now?
Yes, yes, thank you.
Very good. Dr. Diabribo, that was just a wonderful presentation. The content, the illustrations were just amazing. I really thank you for that. We now are into the Q&A session. And as you can see, if you can still submit questions in the Q&A section at the bottom of your screen, and we will try to get through as many as possible. But we may not be able to due to time constraints. So checking, okay. I guess one of my questions as a patient is that how do patients who are newly diagnosed find the right doctor that will help them with their journey with HER2 positive breast cancer? I would think that the participants on this are just amazed that the knowledge base that you have, but honestly, not every oncology practice, focuses on, say, HER2 positive. So what do you do if you are a patient? Do you always get a second opinion? What would you suggest?
So that's a nuanced question. As you know, I work at NYU Long Island, which is a satellite of the main campus. And if you're from New York, you know that the main centers have a lot of buzz. They have dedicated people. So it always starts by starting with your local oncologist. It never hurts. But my answer is always get an opinion for diseases that where you're not sure. Organizations like SHARE on Long Island, we have Adelphi, another patient advocacy, the Manhasset Women's Coalition. They're fantastic resources that can match doctors up, patients up with doctors that are in the community. I'm a community doctor that happens to work for an academic center. So it's not that uncommon to find somebody who's able to at least have the knowledge. We may not all have the resources, but have the knowledge of where to send the patient. So when in doubt, always get another opinion. It doesn't necessarily mean you have to be treated at the big center, but getting an opinion never hurts, even if you take that information back to your doctor. And I've had patients bring back information they've heard at other centers and then come back to us, and we've talked about it and treated it. So my answer is yes, get that opinion. It matters.
Great. Wonderful to hear that. We have a question in the Q&A box. Sandy asks, since HER2 has a gene and a chromosome relationship, should relatives be tested?
So the gene and the difference is that it's not an inherited mutation. The HER2 gene is present in all of us, or it's the actual chromosome 17 is what we all have, and the gene is present on chromosome 17. So it's only amplified in cancer cells. So it's not something that you inherit. There are some studies coming out that there are patients with inherited syndromes that may be slightly more prone to developing HER2 cancers, kind of similar to what we've seen with the BRCA gene and triple negative cancers. As of now, we are not seeing those associations as strongly with HER2, but for example, if there's a strong family history of cancers, HER2 or not, one should get checked. So the answer is no, there's no reason to check for, there is no inherited HER2 mutation. There could be inherited syndromes where HER2 cancers can be part of that profile, such as BRCA2 or Leaf Romani, which is the TP53 syndrome. So that is a different type of testing, but there's no role for family testing for HER2 in particular.
Thank you. What is the recurrence rate for individuals who have been diagnosed with HER2 positive early stage? I would presume you would suggest that they'd be monitored, but is there a high recurrence rate in the short term, or is it in the long term?
So again, very, very important question. If you looked at the numbers I showed you earlier for all comers, HER2 positive breast cancer, stage for stage, have a 25% higher chance of recurrence than HER2 negatives. But that varies between the hormone positive and the hormone negative cancers. So if the cancer is hormone negative and HER2 positive, the recurrence rates are higher in the early part, in the first 5 years. If the cancers are hormone positive and HER2 positive, triple positive, there's also a tail end, a later recurrence. And that's very typical of hormone positive cancers where we see later recurrences. Overall though, the hormone positive, the triple positive cancers have a lower risk of recurrence. So even though the recurrence may be later, the risk is lower. So I would say that it's different for different stages, and it's certainly different for different biologies, but stage for stage, about 25% higher stage 1 HER2 positive versus a HER2 negative cancer.
And along those same lines, if a person has stage 1 HER2 positive breast cancer, but their tumor was grade 3, is that more likely to have recurrence than something with a lower stage?
So not necessarily. It again depends not just on the grade, but also the receptor status. Typically, we find that tumors that are hormone negative and HER2 positive are higher grade. Yes, it is true that grade is a prognostic feature, but we found that by using appropriate HER2-driven therapies, their outcomes are similar. So just having the higher grade is consistent with what we know of HER2 cancers. These are more aggressive. So it doesn't necessarily change the outcome if they give an appropriate treatment.
Great. We just heard in the news that there's a company that says it's developing a blood test where it can tell patients or through their doctors that there is cancer in their body. And even I think they said it was what particular type of cancer. So one of our listeners is asking, is there a blood test to detect early recurrence?
So of course, this is a general question, not so much just for HER2. And the answer is we're not ready for that just yet. There is ongoing studies looking at something that's looking at circulating tumor cells or circulating tumor DNA, which is trying to identify these cancer cells before you can actually see a metastasis. Right now, it's not ready yet for prime time. So my simple answer is not just yet. We know there are certain cancers like colon cancer, for example, where these drugs, this test is being marketed as a way to look for what we call minimal residual disease, where you can't see it on the scan, but maybe it's floating around in the bloodstream, and that's what these cells can find, this test can find. We're not quite there yet for breast cancer, either for detection or for looking for cancer after treatment, but that's coming.
Okay, well, we will be watching for that. Turning to metastatic breast cancer, you indicated through your slides how brain mets are a possibility, unfortunately, for patients. Currently, most patients are not screened in the metastatic breast cancer setting for brain mets. They rather are, their doctor will say, you know, if you have symptoms, then we'll do imaging. Is this going to change in the future, since you mentioned that there might be some drugs to treat brain mets, or do you think that patients will have to rely on their doctor okaying imaging based on a symptom?
That really is it's a population screening question, you know, and I think that it will change because we have drugs that can make a difference. However, screening or looking for breast cancer in the brain is traditionally, you know, the domain of insurances approving it because of survival. I actually disagree with that. In my practice, I have if patients present with metastatic disease, even without symptoms, I do get even if they're asymptomatic, I will get an MRI. The question is how frequently and when do we do them? We know that we don't want to keep putting patients through tests for no good reason. So my answer is that if there is a progression systemically, we should. If patients present with high grade aggressive HER2 cancer and there's a progression systemically, definitely we would check because we could make a difference. In early stage HER2, we're not quite there yet because again, timeline matters. We know that if you have a early small HER2 positive cancer that's been treated, your disease-free survival is 90% plus. So the question is, how many patients do we check? Do we screen everybody or do we just screen the high risk? So I would say that's more of a, something that we do in practice rather than a universal one size fits all for all HER2 cancers that everybody should have a scan. And that also begs the question, who are these patients that are much more likely to recur in the brain? The current COMPASS RD trial that's ongoing is going to answer that question in some way, shape, or form. We are trying to figure out early on who these patients are. What is the difference between patients who have early stage cancer that doesn't recur and the person who has the unfortunate brain metastases 3 or 4 years into, after treatment? Because on the surface, they look equal. So that's where circulating tumor DNA will be studied. And so the answer is right now, screening is more of a clinical And in my practice, like I said, I do it, but not for universally for all patients, but really depending on the risk.
Okay. HER2 positive disease has often been called the disease of riches because of the number of available treatments, and probably also because, like all cancer treatments, things are expensive. So in one of your last slides, you pointed out the clinical trials that are available in both early and metastatic setting at your hospital. How does a patient decide whether to turn to standard treatment first versus to become part of a clinical trial? Does it depend on whether they're in the advanced stage of the disease, stage 4, or would they still have that option or consideration if they're early stage, do standard treatment or do clinical trials? How would you advise them?
So I think a clinical trial is always a good option. We know, as you said, we have wonderful standard therapies. So it really depends on an individual patient's sense of what makes sense to them. We have to be very grateful to the millions of women who have participated in trials, but not participating in a trial is not wrong. It is a scary time. And so it really boils down to your comfort level. I would say both for early stage and for metastatic, there's a role for both. I think that in the early stage, the de-escalation or reducing the amount of chemotherapy is really something that we are looking to do for our patients. So participating in a trial of that nature makes sense. It really boils down to understanding what the trial is, and that's where the treating oncologist and their description comes in. So both for early stage and for late stage, it's never wrong to at least hear about what's out there. And if that risk-benefit ratio makes sense to an individual, go for it. That's the only way we'll move the needle forward, but it always needs to be with a comfort level with your treating doctor.
Very good. There's a question in the Q&A box that said, is there a common location in the body for a cancer, HER2 positive cancer to recur? Or, does that just, chance?
So like most breast cancers, the liver and the bone are common sites. Lung is the other site. And for HER2 cancers in particular, the brain seems to be a particular area where there is what we call HER2 trophism, or HER2 cells like to go into the brain. And that's really the area we're studying, is to see why is it that HER2 cancers have this propensity to show up in the brain. A particular clinical scenario for HER2 cancers often is where the cancer in the body has completely responded, but the one in the brain has not. And we used to think that was because a lot of our HER2 drugs didn't penetrate or didn't go into the blood-brain barrier. That is slowly starting to change. We have studies that show that the drug is there, but those when it reaches the brain, it somehow interacts differently with the brain cells. And that's where these ADCs are becoming more common, where you're treating not just HER2, but you're also treating or they're becoming more popular. You're treating these cancer cells that are not HER2 around there. So there's something about the interaction with HER2 cells and brain, or the microenvironment in the brain, that's a little different. So I would say that in addition to the usual sites where breast cancer can go to, unfortunately, the brain happens to be a special site for HER2.
Thank you for that. That was very good. I'm going to try to combine two questions here. There is a trial called Stop HER2 trial. It's involving the thought that there might be metastatic patients who have taken treatment to the point where they could be totally taken off treatment. I don't know if you are familiar with that or not. And I combine that question with the other part is, what do you think the prognosis rate is for people who have HER2 positive breast cancer in the future? I mean, is it possible that this could be the first subtype that has a cure?
I think that's extremely possible. The idea is that one size does not fit all. And yes, there are long-term survivors, and there are patients who were treated on Dennis Lehman's original trial that are alive and well, doing fantastic, even with brain metastases that have been treated, thankfully. And I think the Stop HER2 and trials of that nature are looking at microscopic cells, tumor DNA, looking at other markers to see who are these patients where we can stop treatment. It's not just peculiar to just breast cancer, though in breast cancer, HER2 is that one area we could potentially do this. We're seeing this in other tumor types too, where there is a group of subset of patients where stopping therapy does not mean that the cancer is going to come back. So I completely endorse that. I think our long-term survivors are another group of patients that deserve ECMO study. So I endorse participating in trials of that nature completely. It is scary to give up a treatment that you know that has worked for years. In the clinic, we all have anecdotes where we have stopped drug, but patients have done well for a while. And sometimes we've stopped because of side effects, but it's never come back. So we have that, but to study that in a randomized fashion is what studies like Stop HER2 is doing. And I think that's commendable. So I think, yes, that is definitely one of the subtypes where the cure is possible.
Well, that is such an optimistic response, and I just welcome that. And in light of time, I think we need to conclude our Q&A session. I want to thank you, Dr. Abreu, for your informative program, your ability to communicate with people. Thank you for all you do. And I urge our participants to please fill out the survey at the end of the webinar. The survey will show up in the browser where the webinar ends, and the link will also be in the follow-up email. All of the surveys are anonymous. So I thank you all for joining us today. Thank you again, Doctor. I wish you all well, and enjoy your day. Thank you.
Well, happy holiday to everybody. Yes, happy and safe. And thank you for allowing me to be part of this community. Thank you.
Thank you.